We're live. Almost there.
I lost my chat box. Oops.
Okay, and we are live. Good afternoon, web shadowers. Thank you all for joining our session today. We have the pleasure of hosting Dr. Lipartia, who will be presenting on obesity medicine. As always, please remember the Google form will be posted in the chat box at the very end to verify your attendance. And with that being said, you can get started whenever you're ready, Doctor.
All right. Well, thank you so much. It's such a pleasure to be here. Thank you, Web Shadowers. You are again doing amazing thing during this time, helping your fellow other students to get all this clinical experience. So I'm Dr. Lipartia, and this will be first shadowing session for obesity medicine. All right, so let's get started. So first of all, a little bit about myself. I Again, my name is Marin Lipartia. I did a med school overseas in Georgia, country, not state. Um, After that, after doing my USMLEs, I did internal medicine residency in Ohio, and I've been attending hospitalist since then, so about 11 years. Um, I was hospitalist in New Hampshire and then Mass General in Boston. And last few years, 3, 4, maybe even 5, um, I I was getting more and more interested in nutrition and obesity medicine science, and we really did not learn much about obesity or nutrition science per se. So it felt like there was really big missing piece as I was taking care of these patients. So as I started delving more and more, last year I went back to training and did obesity medicine and nutrition fellowship at Boston Medical. And currently I'm a medical director of the clinic that I founded, Numeo Medical, which is private medical practice focusing on obesity medicine, which is comprehensive obesity medicine. And I'm board certified in internal medicine and obesity medicine. So if you are interested in obesity medicine, you need to have um, kind of primary board certification in internal medicine or family medicine or other specialties, and you can become board certified two different ways. At this point it may change. So you can get American Board of Obesity Medicine certification through CME pathway, where you attend conferences or some other live sessions. Currently everything online, and then sit for board, or you can go through fellowship route where you do 1 to 3 year fellowship program. There are not a lot of fellowship programs currently, but it's growing because of growing pandemic and growing need. And there are not a lot of obesity fellowship trained physicians. So I was lucky that I did I was in one of these programs last year. And when you are in obesity medicine, really you are not limited to one thing. It's everything that's related to metabolic disorders, right? From obesity to you are managing obesity, diabetes, all the metabolic conditions, fatty liver disease, bariatric patients before and after surgery, malnutrition, and we were doing inpatient consults, etc., etc. So here are some resources if you're interested, and I'll be happy to answer any of your questions about obesity medicine and how to become board certified or how to get involved in this field more. Just let me know. So today's topic, we are going to talk about NAFLD, which is non-alcoholic fatty liver disease. Uh, the reason I chose this topic for this first talk is that it's a growing problem. It really is a pandemic. It's very silent until the last stages where it's really malignant, can be malignant disease. And I want to increase awareness because I did not learn a lot about it during my med school or during residency training. It's been just last few years that I've been learning more about it and seeing more patients. And you will see that majority of my patients, unfortunately, have this condition. And what I want to stress is why I said increased awareness is that importance of early recognition, because this is a condition that can be either deadly or completely reversed with adequate treatment. All right. So let's say when we get patient in clinic, what do? We take full history, right? We ask about symptoms, patients' complaints. Um, we check for signs that are physical exam, um, vital signs, test results, whether it's labs or imaging studies, etc. We think about screening, if there is a role of screening, and we'll talk of screening in this condition, and we talk about treatment options. So let's take this patient, our patient, who is 59-year-old female, and she's coming to our clinic with and seeking the treatment for obesity, for weight management. So as we're meeting this patient, we are taking full history, and in obesity clinic, we take, you need detailed review system, detailed weight history, childhood history, medications, past GYN history, any exposure to medications in terms of weight change, the sleep habits, eating habits. We ask of diet recall, which is, asking what patient ate exactly the last 24, 48 hours, physical activity, and how they deal with stress. So from this patient, we learned that her review system, she does not have any particular complaints. She has been unable to lose weight, but otherwise, she does not complain of any headaches, any dizziness, any lightheadedness, no fatigue, no insomnia, no abdominal pain, no nausea, vomiting. Her bowels habits have been normal. We learned that she has a history of type 2 diabetes and high blood pressure. She's taking two medications, metformin, which is medication for diabetes. We also use for other things, but it's approved for diabetes. Lisinopril, which is medication for blood pressure. She's non-smoker, has never used alcohol, and has a family history of diabetes, heart disease, and sleep apnea. So when we examine this patient, we see that her blood pressure is borderline, it's high, above the target, 143/89. Her waist circumference, which is very important to check in every single patient, is 43 inches. And usually in females, the upper normal is 35 inches, and BMI is 36. That means that she has obesity, which is any BMI. Usually if we go by BMI, but there are also other things. All right. So she comes to the appointment with this blood work that was already done, and we see that her fasting glucose, so sugar, is elevated. It should be under 100 and it's 138. Hemoglobin A1C, which is a marker of kind of tells us how blood sugar has been controlled over the last 3 months, what the average sugar number, average glucose has been, is also elevated in the range of diabetes. Her ALT, that's liver enzyme, is 40, and you see that it's very mildly elevated. For female, upper range of normal is 29 and hers is 40. So one would say it's just slightly up. Her other liver enzymes, other liver tests were all normal. HDL is what we call good cholesterol or high density lipoprotein is 30, which is low, and triglyceride, which is part of lipid panel, is 172, which is high. So based just on these numbers, we can say that This patient has high blood pressure, hypertension. She has diabetes. She has obesity. She has metabolic syndrome. So metabolic syndrome is it's based on some of the criteria of like waist circumference, BMI, fasting glucose, A1C, HDL, and triglyceride. But maybe we'll talk about that another time. And she has only mildly elevated ALT. So not to the point where you will say, oh, it's really severely elevated liver function tests and we need to do something. So the question is, what should we do next? So for now, I want to leave this patient alone and go to fatty liver disease and talk about it, and then come back to this patient, and from what we hear about fatty liver disease, see if there is anything we should do for her. So what is fatty liver disease? Non-alcoholic fatty liver disease. It's hepatic steatosis. Steatosis is fat in the liver with or without fibrosis or inflammation. So with or without some, scarring tissue formation or inflammation. It does not have to accompany. And you should always rule out other causes like viral hepatitis, toxins, alcohol use, etc. So when you rule all this out, then you can say that there is a component of non-alcoholic fatty liver disease. So where is liver located? In the right upper quadrant, right under the right rib cage, right diaphragm. And so again, why I'm talking about the fatty liver disease? It is very prevalent. It's in the US, at least 30% of the population is affected by non-alcoholic fatty liver disease. So I want you to think about it again, at least 30%. In some studies, the prevalence is up to 50% in general population. So every other adult has non-alcoholic fatty liver disease. It's at least 10% in kids, and the number is alarmingly rising. It is number one cause of liver disease in developed countries, in all Western countries. So to how this is kind of progression of liver. On the left side, you see normal liver, then kind of steatosis. This is non-alcoholic fatty liver disease where there is no inflammation, no scarring. Then you get some inflammation. We call it steatohepatitis when there is some inflammation and ballooning. And then this stage where there is a lot of fibrosis leading to, which is scarring, and leading to cirrhosis and high risk for hepatocellular carcinoma and high risk for developing liver failure. And it's not a benign condition. So as I said, up to 50% of US population may have non-alcoholic fatty liver disease, and 20% will develop hepatitis or inflammation, and about 20% will develop cirrhosis and liver failure. So as you can see, the numbers are quite high. And to put that in perspective, look at this graph. So what we see here, this red line, this is all the liver transplant wait list registrants. In the red line, you see the liver transplant for hepatitis C. And you see that as we're becoming really good at treating hep C, how the number is coming down. So transplant, liver transplant requirement or wait listing for hepatitis C. In the green here, you see rising for alcoholic liver disease, and right under, so it's a second leading cause. This is complications of NAFLD. And in females is number one cause of liver transplantation. So non-alcoholic fatty liver disease is a leading cause of liver transplant requirement in the US. So you see that it's a huge huge problem, right? Huge burden. Not just that, mortality risk associated with non-alcoholic fatty liver disease and NASH, as you see, it's all cause. It's so in colors you see liver-related mortality, you see increased cardiovascular mortality, and you see all cause mortality increasing with non-alcoholic fatty liver disease and NASH, which is non-alcoholic steatohepatitis. Um, Interestingly, also is associated with increased heart disease and increase in the number of small particle LDL. So small particle LDL is low density lipoprotein, and smaller the particles is associated with increased cardiovascular risk. So in patients with um, uh, fatty liver disease, the particle size is much smaller than in people without fatty liver disease. So if we take a step back and think about what is fatty liver disease, what is fatty liver? So what you're seeing here is, you may recognize, it's a delicacy, foie gras. And how do they get it? They get it by fattening duck or geese liver by force feeding them. And that was done for centuries. How they fattened these livers of ducks and geese? By force feeding what? High carbohydrate um, food, right? So how does fat accumulate in the liver? Now, one thing important to understand is that there is some fat in the liver all the time, a normal healthy liver, and it's about 5%. When the fat content in liver goes above 5%, that's when we talk about fatty liver disease. Okay, so where does that fat come from? There are three main pathways. One is hepatic de novo lipogenesis, so making new liver, a new fat in liver cells. So lipid synthesis. And that's usually from dietary sources, and usually it's from carbohydrates. The other way is esterification of free fatty acids. Where these fatty acids come from? They usually come from visceral fat. So in people with central obesity, there is high flux of non-esterified fatty acids that go to liver, and liver is loaded, and then this fat accumulates as droplets in that fat accumulates as droplets in the liver. And the third, in normal circumstances at the normal liver, it is from increased dietary fat intake as well. Now, as I said, in normal liver, there is about 5% of fat, and anything above 5% is considered non-alcoholic fatty liver disease. Again, these are three main ways, but this is how the liver, the fat accumulates also in um, healthy liver. So there was one very neat study where they used isotopes, and they wanted to see, they compared normal liver and NAFLD liver, and they looked at the sources of fat formation. In normal liver, most of the fat is from internal plasma fatty acids, and very small from de novo lipogenesis, or fat formation from carbohydrates. In NAFLD, you see how de novo lipogenesis increased from 10% to 23%, and there was a small contribution from plasma fatty acids and meal fat. So that means that in people with fatty liver disease, the main source of fat accumulation in the liver is de novo lipogenesis, or new fat formation that comes mostly from carbohydrates, and we'll see how. So, you know, There have been many studies linking the increase in NAFLD and sugar, and here you're just seeing some epidemiologic data. Um, and as we are seeing increased added sugar consumption and increased sugar sweetened beverages and total fructose, how the prevalence of NAFLD increased. But again, this is just association. It does not really mean that, you know, one is causing another. Now, when we talk about de novo lipogenesis and talking about sugars, there are distinct differences how each type of these monosaccharides work, right, in our body. So when we ingest carbohydrates, there it's either starch. Starch is um, polymer of glucose, so many glucose molecules together, or table sugar. Table sugar is what the equal amount in one molecule of glucose and one molecule of fructose. So unlike starch, which is just glucose, the table sugar has glucose and fructose. And high fructose corn syrup, which we've been hearing a lot about, is similar to table sugar in that it's also glucose and fructose, but it's a little bit more fructose. And you may say, oh, it's just like 5% more fructose and 5% less glucose, but actually, metabolically, it has huge implications. As I said, glucose and fructose metabolize in our body very differently. So, just want to spend a little time here. When we ingest glucose, our body, all our cells can use glucose. So it goes in circulation and gets used where it needs to be used. Whatever is extra goes to liver as a glycogen, which is just collection of many glucose molecules. So liver can save some glycogen and then use over time as needed. The rest goes to muscle as muscle glycogen and gets used over time there. And if those tanks are full, the liver glycogen tank and muscle glycogen tank, the rest will be kind of diverted to making um, fatty acids and ultimately triglycerides and going into lipid depot. What happens when we ingest fructose? Fructose goes to liver, and there is not much space, not much fructose can do. Fructose does not go to circulation and does not directly get used by a lot of other cells like glucose. So fructose needs to be metabolized in the liver first before going to circulation. Now there's huge difference if you get fructose when the um, liver does not have a lot of glycogen. This fructose will be kind of pushed towards making more glycogen. But if the liver glycogen tank is full, what happens with that fructose? It gets diverted. Look at this side, so this red arrow, towards making triglycerides. So you are getting fructose when the liver glycogen tank is still full and it is pushed high hepatic glycogen all the way to high net lipid synthesis. And that's why we think that high fructose consumption, I think, contributes to the liver the formation of fatty liver disease. And as we said as we saw in that study, in the disease of fatty liver disease, the dietary fat contributes little to liver fat formation. Now, so we saw kind of what is fatty liver disease and potential mechanisms of how this condition develops. All right, so we also saw that this our patient did not really have a lot of symptoms, and this disease is not really manifested in early stages with any any symptoms. There are no specific symptoms that patients will come in with and say that um, they have symptoms of fatty liver disease. There are no such symptoms. So as we're looking at this patient who is in our clinic with obesity, high blood pressure, diabetes, metabolic syndrome, and slight elevation of ALT, the liver enzyme, what's next? Okay, we're going to start, treating her for diabetes. We're going to start working on weight management, but is there anything else? Is she high risk? Is fatty liver disease something that we should think about in this patient? So who is at risk? So fatty liver disease has two major risk factors. Number one is obesity, and the prevalence of fatty liver disease has been skyrocketing along with obesity. And number two is type 2 diabetes. It may happen in type 1 too, but more commonly associated with type 1. So type 2. So this is a US obesity prevalence in adults, and in the top you see obesity, and I'll show you other graphs also, more recent ones. So from 1990s to 2015. In all states, the obesity in 1990s was less than 14%. Um, so here in dark red is prevalence of more than 26% of obesity. And you see that how diabetes prevalence is going up as well. And this is US obesity prevalence in 2011 and 2019. And see this huge difference. So in 2011, red states are 30 to less than 35% prevalence of obesity. So some states have up to 35% prevalence of obesity, and the states in yellow are up to 30%, and there are some states with less than 25% prevalence of obesity. Just within a decade, see what's happening. The dark red are the states where obesity prevalence is more than 35%. More than 35%. So you see, just in 2011, there were no states with obesity prevalence more than 35%. There's only one state where obesity is less than 25%, but it's more than 20%. And there are no states where obesity prevalence is less than 20%. Higher BMI, so overweight and obesity, which is roughly BMI above 25, is an independent dose-dependent risk factor for fatty liver disease. So dose-dependent meaning that higher is the BMI, higher risk of non-alcoholic fatty liver disease. So up to 90% in patients with severe obesity have fatty liver disease. So let's say in obesity medicine practice, at least 90% of my patients who have obesity, and most of them have diabetes, have fatty liver disease. Now, it's just kind of some statistical epidemiologic studies comparing the people with normal weight, metabolically healthy obesity, which I'll talk about in a second, and metabolically unhealthy obesity. So you see that when BMI is normal, there is very small low risk of NAFLD. The metabolically healthy obesity, what does it mean? So there are different types of obesity, and we call it metabolically healthy when the fat distribution is mostly subcutaneous, so under skin, and there is no fat inside and around organs, so there is no visceral adiposity. The fat tissue has very different quality when it's under skin, and as opposed to when it's in visceral organs, because it releases a lot of pro-inflammatory cytokines. Changes, affects insulin sensitivity, changes the glycemia, changes lipid profile. So, but even as you see, even in patients with metabolically healthy obesity, there is some increase in the risk of fatty liver disease. And it goes higher as the fat accumulation moves from subcutaneous tissue, more, kind of apple shape, around abdomen and around visceral organs. Okay. Now, we'll talk about how to diagnose NAFLD in a little bit, but there are different ways, and no matter what tool you use to diagnose fatty liver disease, whether it's plasma ALT, which is not very sensitive, or advanced testing, patients with type 2 diabetes are almost twice as likely to have fatty liver disease compared to patients without type 2 diabetes. So having type 2 diabetes is like twice as high risk of having the diagnosis of fatty liver disease. Now, we said that our patient had slight elevation of ALT, right, this liver enzyme. ALT is not very sensitive. In other words, it if you screen patients with ALT, you will have a lot of patients with normal ALT and full-blown NAFLD. So, for example, in patients in this study, they looked at the patients with NAFLD and NASH who have type 2 diabetes but normal ALT. So all these patients had normal ALT. But look here, patients who have type 2 diabetes, severe obesity, BMI more than 40, and normal ALT, the risk of NAFLD, they had 90% of these patients had fatty liver disease, even with normal ALT. So that's just one thing I want everyone to remember, that normal blood work does not rule out fatty liver disease, okay, or even NAFLD, or even steatohepatitis, which is more advanced. All right, so let's say if we decide to, as we saw here, our patient is very high risk for having fatty liver disease, right? She has obesity, she has central obesity because of her waist circumference is high, she has metabolic syndrome, she has diabetes, type 2 diabetes, so she's high risk, very high risk for having fatty liver disease. So there are different ways of checking. There are some non-invasive tests like ultrasound or so-called fibroscan or MRI or CAT scan, liver biopsies to see the stage of inflammation. You will not be able to see the stage of inflammation on non-invasive testing, and there are some advanced fibrosis scoring system. I will not go into details on that one, but it's just important to know that who to know that it's very common. Patients with diabetes and obesity are very high risk of having NAFLD, and we should be aware of that. Even with normal routine tests, the likelihood of them having this condition is high. And remember that some patients will develop liver failure. The number is high and it's a leading cause of liver transplant. So just be aware of those numbers. So, okay, now what? So our patient has slightly elevated ALT, and we're going to screen. We're going to look for NAFLD. And at this point, let's say if our patient had normal liver tests, completely normal ALT, would we still check, then do tests to look for NAFLD or no? What does it's the guideline from American Association of Studies on Liver Disease. They say that routine screening for NAFLD in high-risk group is not advised at this time because of uncertainties surrounding diagnostic tests and treatment options, along with lack of knowledge related to long-term benefits and cost effectiveness of screening. Now, I want you to hold on to that um, statement that screening for NAFLD by AASLD is at this point not recommended. And the reason it's not recommended is there are no treatment options. So let's examine that a little more. What are treatment options for patients with NAFLD? Cornerstone is weight loss, and this include weight loss with lifestyle modifications, anti-obesity medications, and bariatric surgery. Physical activity and exercise very important, as well as pharmacotherapy. So now let's start with weight loss. So patient with there are two ways of thinking about it. Patient with obesity, whether patient has NAFLD or not, you are going to work on with a patient on weight loss, right? So does it change your treatment plan? To me, it does, in a way that I still treat obesity, but when patients know that they have NAFLD, and it's we treat it more as aggressively as possible, because now you will see. So if you look at this screen, just 3% of weight loss improves steatosis, 5% improves ballooning, and inflammation, and more than 10% of weight loss improves even fibrosis. So even when someone has advanced fatty liver disease with scarring, 10% weight loss can improve this stage and reverse disease. What that means is that in these patients, we can avoid, with aggressive treatment of obesity, avoid progression to liver failure and requirement of liver transplant. So I think this is huge, right? I mean, yeah, targeting weight loss to avoid liver transplant. Unfortunately, it's hard to maintain weight loss, and it's a different topic, and that's why the obesity treatment should be very multidisciplinary and comprehensive, and not recommending just eating less and moving more. Now, what kind of diet do we recommend for patients with NAFLD? There's no official statement, because we don't have enough studies to say this is specific diet for to reverse NAFLD. What's clear is that no matter what kind of diet you start the patient on, as long as it results in weight loss, there is improvement in NAFLD. Now, um, just I'll just go down those few dietary intervention now. Low sugar diet. I think low sugar diet, it really really makes sense, right? Because we saw that in NAFLD, the majority of um, fat accumulation comes from de novo lipogenesis, or dietary sugar, and especially fructose, and high glucose can do that as well. Um, and there have been some studies where they started, there was a study in adolescent boys where they started them on sugar-free diet, and it resulted in improvement in the decreased fat in the liver, even without weight loss. Um, so if we ask patients to not take any sugar, then the question usually comes up, all right, doctor, can I use non-nutritive sweeteners, which are sugar substitutes? On that, we don't have clear answer. So um, some studies show that, and those are preclinical studies, that the sugar substitutes, and especially some of those, may change um, microbiome. And so we don't know how long-term that's going to affect the um, health, probably not in a positive way. Um, Now, we know that people who changed from sugar sweetened beverages to sugar substitute non-nutritive um, sweetener beverages, they had decreased in weight, so it was good for weight loss. There's also in, for example, Framingham Heart cohort, um, heart study cohort in people who were drinking diet soda, their ALT was normal, but in the people who were drinking sugar sweetened beverages, their ALT was average higher. Again, some association, but it's just epidemiologic data. We cannot say if that was the cause or not. So again, it probably in my clinic can be at least temporary substitute if someone is trying to transition from high consumption of sugar sweetened beverages to diet soda, etc., but probably not the good long-term solution. The other question that I get asked all the time is, okay, which one would be better for fatty liver disease? Is it low carb or low fat? By default, people think that because it's fatty liver, low fat should be better. There are some studies comparing low carb to low fat. Both help to, again, as long as it results in weight loss, it helps with decreasing fat in the liver. And low carb has shown to have some advantages in improving more metabolic profile, like improving good cholesterol or HDL, decreasing triglyceride, and decreasing insulin. And insulin is another hormone that, when you get high carbohydrates, insulin level is high, and then it really affects is positively associated with NAFLD. We have some clinical data and good results on patients who were on Mediterranean diet and had a better result than low fat, high carb diet. But again, that it was not low fat, low carb, it was low fat, high carb. So it's not apple to apple. But Mediterranean diet has been proven to have good outcome on patients with fatty liver disease. And ketogenic diet, again, very small studies. They did not look at histology. They looked at ALT, and we saw ALT is not really good marker. So we just need better studies. The same with intermittent fasting. We have some data, but not the good studies. Now, when we talk about weight loss, again, the dietary intervention and lifestyle intervention is very important, but we should also once we talk about dietary interventions, talk about pharmacotherapy. There are some FDA-approved medications for weight management, and in patients who meet criteria and who are unable to lose weight with medical therapy should be referred to bariatric surgery, and bariatric surgery has shown to improve the non-alcoholic fatty liver disease. And again, we should do everything for these patients to avoid them getting to liver transplant, which I think is really devastating. So again, for fatty liver disease treatment, the cornerstone is weight loss. We saw that weight loss more than 10% improves even fibrosis, let alone just fat in the liver. The next is exercise. In exercise, it's important that for patients, when we're talking to them about exercise, we should not talk about exercise in the context of weight loss. Exercise has shown to have the benefits of its own for fatty liver disease. And it has shown that rigorous exercise improves histopathologic findings on fatty liver disease and helps to decrease fat in the liver even without weight loss. So that's important, that more physical activity is inversely associated with fat content in the liver. And the other thing is pharmacotherapy. Exercise, it just has a lot of other benefits other than just how many calories you burn during exercise, right? So pharmacotherapy for NAFLD. So we don't have really medications targeted for fatty liver per se, but there are few things that are approved for patients. One is pioglitazone, which you may have heard. It's a diabetes medication. Actose improves liver histology, patients with and without type 2 diabetes. Um, and we should only use for patients who have proven NAFLD on biopsy, because that's how this study was designed. We also have vitamin E, which is recommended in non-diabetic patients with proved NAFLD. The only major thing we should be aware of that it may increase risk of hemorrhagic stroke, but it decreases risk of ischemic stroke. Um, and is not recommended in patients in diabetes because it was studied in non-diabetic patients. There may be some role in the vitamin D. In general, patients with obesity are at high risk of having vitamin D deficiency, so that's very important. And vitamin D may have some anti-inflammatory um, effects, and how it works for NAFLD is not really exactly clear, but there is some data that it decreases ALT and improves the histopathology, but there are more studies underway, so hopefully we'll learn more about it. So again, if we go back to our patient, now that we know that NAFLD can be very deadly, it is a leading cause in women, like our patient, to require liver transplantation. Um, our patient is very high risk with having diabetes, obesity, and metabolic syndrome of developing NAFLD. And let's say our patient did not have this mild elevation in ALT. Should we screen or should we not screen? So as we said before, the guideline from American Association for the Study of Liver Disease recommends that we should not screen patients with NAFLD because we don't really have good treatment. And regardless whether we have NAFLD or not, we should treat her diabetes and obesity, which is again true in a way that yes, we should treat her diabetes and um, obesity. Um, this is from American Diabetes Association. They are recommending that patients with type 2 diabetes and prediabetes and elevated liver enzymes, which we saw is not really great screening tool, or fatty liver, should be evaluated. So they're recommending for um, screening. And European societies do recommend that high-risk patients be screened for NAFLD. So these guidelines are still changing, and as we have more data, I'm sure that, and as we get better at treating NAFLD and reversing, they will advocate more for screening. So NAFLD, it's spectrum that is increasing in prevalence due to obesity pandemic. The diagnosis requires high degree of suspicion. Again, there are no symptoms until the late stage. There are no specific complaints, and the blood work a lot of times in terms of liver specific is completely normal. We need to suspect all high-risk patients. If you rely just on the blood work on ALT, you will miss at least 50%. And the cornerstone of the treatment is weight loss. And it's important to recognize this condition and treat the risk factors as aggressively as possible. So I think that is my last slide. So I advise you to not let the circumstances negatively affect your education. I think what web shadowers are doing is that it's wonderful that it will help you to kind of fill in the gaps. Um, if you have any questions, I'll be happy to answer some now. I don't know if we have, I'm not seeing chat box yet. If you have any questions about fatty liver disease or anything about obesity treatment, let me know. Here's my email. and you can find me on social media, and this is my clinic handle and my personal handle. And thank you everyone for attending. Oh, I see some questions now. All right. So, Sophia, should I start answering these questions now?
Yeah, that would be great. Thank
All
you.
right. Yeah. Okay. So I see some great questions. How much does genetic or epigenetics play a role in FLD? Yeah, that's a great question. We just really don't know. I don't think I can answer that question 100%. I'm sure it has effect, but what we're learning is that by environment and lifestyle and eating and dietary interventions, you can really change the expression of epigenetics. So yes, genetic and epigenetic has a huge role, but at the same time, these are, one person may have higher risk than other based on genetics, but those are a lot of things are modifiable with the lifestyle interventions. Now the question, how do you know if the fat is in patient is subcutaneous or visceral? That's a great question. So there are a few ways. One is the exam. So phenotypically, patients, so when you are seeing this so-called the pear-shaped obesity, when there is not visceral obesity, it's more subcutaneous distribution. Also, you check waist. So that's why BMI is not really accurate, because the same BMI to different person may mean completely different things. Like one will have, uh, even if the fat percent is the same, they may have different distribution of the fat, and the risk profile, the metabolic risk profile, is completely different. For example, so we check waist circumference. Waist circumference in general for female should be less than 35 inches, and for male less than 40 inches. So above that, you're thinking about visceral obesity. And then you can also check body composition analysis, and with that, the machine will calculate the internal, abdominal, visceral versus subcutaneous fat distribution. But I think the physical exam is the best tool. There's also pinch test, where you can check whether it's the subcutaneous fat or the visceral abdominal. Now, visceral abdominal is really malignant fat and very pro-inflammatory. Uh, how do you navigate advising on diet while also incorporating social determinants of health? Example, low-income patients who can't afford healthier food desserts. Oh, that's a great question. So, yes, it is very, very, very challenging a lot of times. So, um, we work with, so for example, in patients in low income patients, we work with dietitians, and kind of try to teach them how, teach them like shopping, how to cook with least processed food. We also refer, for example, where I did fellowship in Boston Medical Center, we had food pantry. We were utilizing that on a daily basis. We would refer patients, and they would get, Boston Medical Center has this wonderful teaching kitchen, and also um, food pantry and the garden on the roof. So they would be getting the fresh supplies there. So referring to social worker and working with dietitian, it's this is the most challenging part, I think, in obesity medicine. Could you explain more on the findings about exercise without weight loss and fatty liver disease? What are the differences of treatment? So um, in patients with fatty liver disease and exercise, the exercise intensity was inversely associated with the fat content in the liver. I can, maybe later on YouTube in comments, I can link those studies. I did not, because I did not want to go too much into, study details. think I may have it somewhere, but anyway, I will link those studies in comments. How's that? What are the differences of treatments and approaches performed by bariatric physician versus obesity medicine physician? Okay, great question. Yeah, so um, a bariatric physician is usually a surgeon who performs bariatric surgery. Now, there are different types of bariatric surgeries in terms of procedures, and obesity medicine physician. So we as think of it as a continuation of internal medicine or family medicine. So we do medical treatment of the patient. So most of my patients are in obesity medicine treatment. We cannot I don't like non-surgical versus surgical, right? It's one continuum. So obesity medicine physician will treat patients with obesity. It can be before surgery, starting on weight management medications, working on the risk factors. So all the medical management, the nutritional optimization, assessing for malnutrition. And then for patients who meet criteria, for example, they have obesity, BMI more than 40, they've been unable to lose weight or are regaining weight after weight loss, or have a lot of other metabolic conditions and need bariatric surgery, we refer to surgery. And then we still follow these patients after surgery, because bariatric surgery is not having surgery done and that's it. It's after surgery you need the very strict diet to follow. Patients after bariatric surgery are very high risk for malnutrition and some vitamin deficiencies, so they need to continuously follow up with obesity medicine physician for post-treatment. Also, at least a third of the patients after bariatric surgery will have some kind of weight regain. And even after bariatric surgery, a lot of times we start patients on weight management medications. I don't know if that answered your question. If not, reach out and we can chat more. What are the process of they become certified as a doctor in the US after going through medical school in Georgia? Um, Yes, so I after med school I did the USMLEs, step 1, step 2, CS, CK, and step 3. Applied same way to um, residencies. So before residency, actually, I applied and requested shadowing, so-called observership, so that I would kind of get familiar with the US system, and then applied for residency and participated in the match. So you just go through, first step is doing USMLEs. Could you explain more about metabolically healthy obese versus metabolically unhealthy? That's a great question. So what is metabolically healthy? So as I said, obesity it's a metabolic disease and is associated, it's not just the fat content, it's abnormal fat accumulation. And the fact that this fat is metabolically active, is pro-inflammatory and releasing a lot of interleukins and tumor necrosis factors, etc., increasing insulin resistance, right? So based on where is the fat distribution, the fat tissue has different qualities. So when fat is in subcutaneous tissue, that's more what we call kind of protective fatty tissue. That fat tissue is not as inflammatory and is not associated with insulin resistance, is not associated with metabolic syndrome, does not cause the change in lipids, and is not very high risk for example, fatty liver. When the fat is in visceral organs and in the has a central distribution, that fat tissue is very pro-inflammatory, and because of that is associated with all this insulin resistance and change in the lipid profile, and is a very high risk for coronary artery disease. Is NAFLD reversible? Can it return after patient is healed from it? And is it a lifetime issue? That's Good question. So it's yes, yes, and yes. So is NAFLD reversible? Yes, it can be completely reversible, especially in the early stage when we don't have a lot of fibrosis. It is completely reversible with weight loss and right diet. You can return it. It's just like obesity. Someone may lose weight and then they may regain. Any chronic condition that requires to change, whether it's lifestyle or something that's affecting the disease progression. If you reintroduce it, then it's going to come back. So think of it as it's not a good comparison, but like, for example, you can reverse alcoholic liver disease by abstaining from alcohol for long time. And this, if it's not like advanced cirrhosis, you can reverse disease. But if you start drinking again, the disease is going to come back. Is it a lifetime issue? So again, it can be completely reversed and the liver can look completely normal. But if someone develops the same metabolic risk factors, develops diabetes again, gains weight again, changes diet again, then it may come back. So it is reversible, but it's highly, it can be reversed, but it can relapse later on again. Those are great questions. If it again, I'm just saying this kind of one-way chat, and I'm sure that some of the answers I gave you may not have answered your questions 100%. So if there is anything you have a follow-up question, or if I did not cover it completely, or maybe I misunderstood some of the questions, just feel free to reach out. Again, I'm Dr. Lipartia on Facebook, Instagram, Twitter, LinkedIn. You can find me anywhere. This is my email, and I'll be happy to answer direct questions or talk to you directly if you have any questions.
Thank you so much, Dr. Lipartia. This was a wonderful presentation. I know everyone learned so much from you. Thank you so much for taking the time again to do this.
Yeah, thank you. Again, it was, I think I know that the listeners are kind of different from, I prepared this for different audience, and so hopefully it was clear for everyone, and if not, anyone can reach out, and we can talk more.
Yeah, thank you so much. It was great. It
All
was a
right.
wonderful presentation.
Thank you,
And for
Sophia. Yeah.
Yeah, thank you. And for everyone watching still, the Google form for your attendance has been posted in the chat box. That'll be open for another 30 minutes. So I'll close it at 3:33 p.m. Eastern time. And thank you again. Thank you
Thank
for
you.
presenting.
So I'll see you next week, and we'll talk about obesity.